Hi, I'm Dr. Steve Sarkisian. I'm the founder and CEO of Oklahoma Eye Surgeons in Oklahoma City, and this is a lecture entitled Why I Don't Do Trabs Anymore. I'd like to thank the organizers of this event for inviting me to speak at this excellent meeting. Here are my financial disclosures for this lecture. Another name for this lecture could be What? No Trabeculectomy? Why your friendly neighborhood glaucoma specialist didn't filter your patient. So it's important to understand that I'm able to make a statement that I don't do trabeculectomies anymore because we have had so much recent innovation in glaucoma surgery. The reason for that is because trabeculectomy not only kills the enemy, but it kills the whole village too. We're trying to push back the darkness and prevent blindness, but we need to do it in a targeted way that doesn't cause so many side effects. Here is a picture of a bleb leak, and the side effects from trabeculectomy are so significant: infection, bleb leaks, hypotony, bleb dysesthesia, and astigmatism. These things are very significant and significant impediments to the happiness of our patients and their health. So can we beat trabeculectomy on efficacy? Well, the primary tube versus trabeculectomy study definitely showed that we have lower IOP and fewer meds than with a trabeculectomy than with a primary tube shunt. Trabecular microbypass and canal surgery only have a modest improvement of IOP and typically are not indicated in patients with a very high IOP on maximally tolerated medical therapy. And we do have decades of experience with fixing overfiltering or failing blebs. However, the problem is, as we've said, we have to ask the question that these side effects, are they acceptable? The side effects from trabeculectomy can be very significant. And can we kill the bad guy while he's sleeping without offing his wife, his kids, and his neighbors? I suggest that we can. But it's taken some time and some progress to get us there. This is a great ad from when Alcon bought the Expression from Optinol. The 1960s called, and they want their filtration surgery back. And they had some great stock footage of some, presumably from the 60s, of these scientists in their lab coats, all men, all white men, of course. And they want their filtration surgery back. Now, the Express obviously was not MIGS, but it marks a progression in our desire to have more control over outflow and to allow the flow to be restricted to some degree, taking advantage of Poiseuille's law. So how do we get the IOP low enough? Well, really, does everyone need an IOP of 10 millimeters of mercury? Sure, nothing can beat a trabeculectomy on efficacy, but is it necessary? What does low enough mean for our glaucoma patients? Well, so there's several questions that I ask myself when I evaluate every patient with glaucoma to try to determine what their target IOP is, but also really what their what our goals are. So, what is their glaucoma staging? Are they mild, moderate, or severe? What is the number of medications that are required to keep the pressure at target? What is the target on the current treatment? And what is the baseline IOP? These are all critical things that I ask myself when I'm trying to lower pressure and decide what low enough is for them when picking their surgery. So you also need to have an honest conversation with the patient. So, there is a patient behind those eyeballs. You're not treating a number. You're not treating an IOP. You're treating a patient. So, you ask these patients questions. How do you feel about taking medications? How important is being off medications to you? Has anyone in your family gone blind from glaucoma? That's going to be a critical role because it not only cues you into how quickly they're going to progress, but also their perceptions about their disease, their anxiety about their disease, and how best to go about treating them. So questions that you ask as we individualize the care for each patient is, what do they do for a living? How old are they? Do they live alone? What are their hobbies? What's an average day like for them? What do they do every evening? Sounds a lot like a refractive surgery consult, doesn't it? But again, we need to determine what it is that the patient does every day to determine what's the best surgery. Obviously, here in Oklahoma, I have several patients that are farmers and ranchers, and they're not going to stop feeding their cattle and baling hay simply because they have eye surgery. They might be able to do it for a day or two, but that's about it. So really thinking about what these folks do is going to be critical in helping pick what this glaucoma surgery to do. So how can we avoid doing, or at least delay doing a trabeculectomy? Obviously, the title of my lecture is somewhat facetious. Trabeculectomies are still done all over the world, and they do have significant side effects, but they are an effective surgery. And some patients, it's certainly not wrong to do a trabeculectomy. I don't want to give off the wrong impression. What I'm going to do is I'm going to kind of show you a way that you can practice glaucoma without doing trabeculectomy. It's still realistically an alternate treatment algorithm, but more and more surgeons are really converting to a rare or zero trabeculectomy practice. And what I'm going to show you is that the ability to do this is going to continue to improve. So this is a case of a 60-year-old dentist with primary open-angle glaucoma, and is referred to me with a pressure of 25 in the right eye and 22 in the left on maximally tolerated medical therapy. His Tmax was 50 millimeters of mercury in the right eye and 35 millimeters of mercury in the left eye. Best corrected visual acuity was 20/60 in the right eye and 20/40 in the left eye. And he's had SLT in both eyes and had phaco with a trabecular micro bypass in the right eye, and has a visually significant cataract in the left. Both eyes have shown progression on visual field. Both eyes need surgery. Here you can see the visual fields for this patient. Over time, you see that the right eye, the superior arcuate visual field, has progressed to a superior altitudinal field, and what was an inferior nasal step has progressed to a full inferior arcuate scotoma. And in the left eye, the nasal step, the inferior nasal step, has progressed. So, in the MIGS era, can we individualize care? 6 to 7 years ago, this patient in my practice would have gotten either canalplasty in both eyes or probably an express shunt in the right eye and canalplasty in the left eye. But what about now? Well, the right eye needs a pressure in the low teens. The conjunctiva and the canal have not been touched except for that eye stent. But the rest of the canal and the trabecular meshwork is intact. The eye is pseudophakic. The patient has no problems paying for and taking medications for his glaucoma. So what non-trab options are there? Well, there's the OMNI procedure, which is a combination of ab interno viscodilation of the canal and ab interno goniotomy. There's ABIC, which is really sort of the coined name for ab interno canalplasty using the catheter now by Nova Medical, but formerly it was called the iTrack microcatheter, which was the same catheter that was used for ab externo canalplasty. There's ab interno goniotomy, and you can think of multiple ways of doing that, either with the Trabs or the dual blade, or the gap procedure using a suture, or again the iTrack microcatheter. And then combining either of these canal procedures with ECP. ECP is really the first MIGS procedure in some ways, and is done through a phaco incision, typically a similar type of incision. And the endoscopic cyclophotocoagulation can be done either 270 degrees or 360 degrees at the surgeon's preference. Another question I like this is there still a role for ab interno canal stenting in an off-label fashion? There are many opportunities, since the rest of the canal is intact, to consider this as an option. However, this patient's pressure is likely too high for that to be satisfactory. So my surgery of choice for this patient in the right eye was I combined the OMNI procedure with ECP. I typically perform full 360 degrees of viscodilation and full 360 degrees of goniotomy because I want to get the maximum effect. So ECP plus OMNI is an excellent opportunity to not do a trabeculectomy because you really have two different mechanisms of action. You have the ECP component, which decreases aqueous production. And here you can see a video next to an animation showing the whitening of the anterior ciliary body. You really are only treating the anterior third. And if you do this correctly, where you complete the ablation of the anterior ciliary process and get all the peaks and valleys, as it were, as you paint across, and you're careful not to touch the iris and not to pop the ciliary processes, you can have, you will see minimal inflammation with ECP. there have been papers in the literature that demonstrate that the rate of excessive inflammation and CME are not any higher with, particularly CME, or the rate of CME is not any higher with ECP than it is with cataract surgery alone. However, obviously, surgeons that see a lot of CME, particularly retina surgeons, have a referral bias, and so they tend to think that everyone with ECP get CME because those are the patients that they see, but it's simply not the case. Now, on the right, you have a video of the Omni procedure, and the Omni procedure is an ab interno, again, ab interno 360, and you could just use the Omni device to do viscodilation and forego the trabeculotomy if you wanted to titrate it. But here you see just with the tip unroofing the trabecular meshwork and then using the catheter inside to catheterize the trabecular meshwork, doing and the canal using the catheter one side at a time. It actually extends for 200 degrees, and as you withdraw the catheter, it ejects perfect aliquots of viscoelastic. Again, I use a cohesive viscoelastic, and you can't over dilate the canal because as you withdraw it, it releases it. That's perhaps theoretically one disadvantage of the ABIC procedure using that catheter. It's an excellent procedure, but if you stop while you're pulling and the assistant is continually turning and clicking the device, you can get a Descemet's rupture. Here you see very slow goniotomy. It's important that as you do this, you use a slow push-pull motion so that the catheter doesn't simply pull out the way you went in. You actually want to do the otomy procedure, and here you can see as I slowly pull back. Another good technique you can do is spin the wheel as you're pulling back in order to unroof the canal in that area. And here you can see as I get my focus after removing the gonioprism that it is indeed unroofing the canal. This obviously is not the patient in our case. As you can see, this patient is faking. So the result of this patient having combined ECP and the Omni procedure was that they ended up with a pressure of 10 millimeters of mercury, still on 2 medications, and the vision improved to 20/25. So what else could I have done besides the trabeculectomy? Well, uh, you could have done Omni alone. Frankly, you could have done uh, any canal-based procedure alone, and just leave the eye stent. In an eye that has a previous first-generation eye stent or a second-generation inject, um, you can do the viscodilation around where the eye stents are. I usually just leave them in. Unless for some reason they're not implanted well, but even then I can just. I've seen many first generation eye stents that I've sort of repositioned if I didn't think they were in well, and still did the Omni all around it. So, and the same thing with aberrant canaloplasty. Um, Remember though, this patient has no trouble being on meds, so probably doing any of these canal-based procedures alone would be adequate. But this patient had a significantly high pressure, and there are times when you do canal-based procedures and we don't have a canalogram. We don't have an angiography equivalent for the canal. The canal is more like a lymphatic vessel, really, than a blood vessel. So it's not. It's a little more complicated. So, because I wanted to get the pressure down fairly definitively, and I wanted to hedge my bets in case an outflow procedure was less successful or temporarily successful, I felt the addition of ECP was warranted, and I frequently combine ECP with the iStent, the hydrus, or all of these other any kind of canal surgery. ECP, when done well, definitely is an important adjunct, and I would make an argument that 360 degrees of ECP is going to be superior than 270 from an IOP standpoint. It does take a little longer. You do have to make a second incision, but it's worth the time. It's important when it comes to MIGS. You have to take the time to educate your patients about the long term. You have to do that with any surgery. I mean, with trabeculectomy, the devastating complications you need to tell people about. And if you really gave an appropriate informed consent, there'd be far more people saying no to trabeculectomy. In fact, that's already happening. I mean, I see many patients for second and third opinions who simply refuse to have a trabeculectomy after they've heard about it and they realize that there are other options. The word is out, and so they come to me seeking something else, determined to have something else, which has certainly made my job a lot easier in the last 6 to 8 years. But you still have to educate the patient that there is no cure, but there are good treatments, and we'd like to start with a safer treatment, and gradually work up to being more aggressive depending on what their particular glaucoma is throwing at them. Again, I like to reiterate the cardiac stenting angioplasty versus cabbage analogy. Patients understand this very well, and they understand that because cardiac disease is so prevalent, that if you start with, when you identify an outflow problem, you start with the easiest restoration of the outflow, not bypass of the outflow completely. And in this scenario, bypass is, even though there's trabecular microbypass, True bypass is bypassing in the eye is bypassing the trabecular meshwork in Schlemm's canal altogether and routing fluid to an extraocular reservoir of some kind, um, whether it's aceton or an encapsulated area under the conjunctiva. And then unpacking the possibility of a two-stage procedure. So, and I'm very upfront with people. I say that there's a certain percentage of patients that, particularly if they're older and they have high pressure, where canal-based procedures might be less successful. And but the saying that, well, so-and-so patient will eventually need a trab anyway, so why bother? Well, get the patient involved in that process, because you don't know how many years you can get them with ab internal canal procedures. You just don't know. There's no way to predict, and you really shouldn't paternalistically decide that for the patient. You need to include them in that discussion. So, a brief word about adding sustained release medications. Um, as we discuss the fact that how do we strategize to prevent doing trabeculectomy? Well, having the backup of say Durista or sustained release bimatoprost implant, particularly when patients maybe are having a little bit of a steroid response after canal surgery, it would be totally appropriate. And even after the postoperative, getting them out of the postoperative window and considering a combination of SLT and Durista on different days to improve your ability to get the patient off medications. It's an excellent strategy. And I'll say this, that doing SLT after someone has had the Omni or ABIC or any kind of any goniotomy procedure, be it the KDB, the Trabs, or whatever it might be, even if they weren't necessarily good candidates for SLT before because of their level of IOP, I tell people after surgery, well, it's a new day. We've had a reset. We've had a surgical reset. We can try that again. And that's something to consider. And this is really where sustained release can really shine in achieving the so-called MIGS dream of being able to be minimally invasive and also minimize eye drop use and get us closer to these MIGS procedures to Trab-like outcomes. Well, what about subconjunctival MIGS? Because, if that patient in my case, the Omni wears off, the ECP wears off, and we're adding meds again, and the pressure starts to get above target again, what are we left with? Well, I suppose we could repeat the ECP, or we could do transscleral cyclophotocoagulation, or we could do micropulse, which is less effective, but certainly much safer. But some people, you just have to bypass the system. But, you don't have to, you still have to do a trabeculectomy. You can shunt aqueous to the subconjunctival space using the Zen. And here you have a picture of one of my patients during an ab interno Zen procedure, where you can see the implant there. And you, on the right, you see it in its good position in the anterior chamber. So the Zen gel implant can be ab interno or ab externo. Most glaucoma surgeons I know are doing 90% ab externo at this point. And it uses the Zen uses Poiseuille's law of laminar flow, which means that really the flow of fluid through a cylinder is modulated or regulated by the length of the cylinder and the diameter of the cylinder. And under 70 microns, you really start to see restriction of flow through a cylinder, and then the longer the cylinder is, the more restriction you're going to have more restriction to flow you're going to have. This is important because our agenda is safety, and we're trying to minimize the risk of hypotony. And in fact, hypotony with the Zen is very rare. It's not impossible. I have had one or two out of hundreds of patients have a transiently slightly shallow chamber, but never a flat chamber. I've had one or two patients with low choroidals, but not kissing choroidals. And I've had one patient with a suprachoroidal hemorrhage that was very old and on anticoagulants. So these things can rarely happen, even with the Zen, but they're rare. Whereas with the rate of hypotony with trabeculectomy can be, depending on what data you look at, could be as high as 20%. The Zen has a one-handed injector, and you see this blue injector that you can push forward. The first half releases the Zen. The second half withdraws the needle from the eye.
This is Dr.
This is a
Steve
video
Sarkisian
of
University of
Aventurno
Oklahoma.
Zen implantation.
And this is
I still do
a
Aventurno
video
Zen with
of,
phaco often.
the Zen implantation.
What I start
Where you
with
can
is
see
I
I'm
make
marking the eye with 3 millimeters
some
posterior to
goalposts,
limbus,
marking 3 millimeters
with 3
posterior to
markings in
limbus,
the
so I can
supranasal quadrant.
judge well where I'm coming out with the Zen. And I make them at 12 o'clock. It's important to be at 12 o'clock and not overly, and not too nasal with your implantation of the Zen. Otherwise, you'll have a large nasal bleb, potentially, or which can be painful. Or you're at higher risk of exposure of your Zen. It's important, if you're doing this combined with phaco, that you make your phaco incision slightly directed so that it can go towards 12 o'clock. Or if you simply want to, if you do very temporal clear cornea blebs, or temporal clear cornea phaco, you may consider making a second incision for your Zen inferiorly pointing toward 12 o'clock for this purpose. It's important that mitomycin C be injected. It can be, I usually do it after the case. But here's an example of where I do it before the case. Several important things for success with implantation of Zen. One is to use an adequate amount of mitomycin C. And here I'm injecting 60 micrograms of mitomycin C, approximately 10 millimeters posterior to the limbus using a 30-gauge needle. We don't have to worry about that small 30-gauge needle track leaking down the road. The eye is full of viscoelastic, and I place some preservative-free lidocaine inside the eye for anesthesia, and that usually is adequate.
The mitomycin further posteriorly in order to prevent the mitomycin.
If you look at the clinical trials for the Zen, the results showed 12-month IOP to be around 15, but I really believe that the IOPs can be lower if you use more mitomycin C than was used in the study. So here I'm going into the eye with the Zen.
This is for the safety of keeping the Zen in place.
It's important to get good visualization, and you will see that I'll place a gonio prism on the eye because I want to be anterior to trabecular meshwork. If you go through trabecular meshwork, you could be fine, but you also can cause some bleeding,
visualizing with a
and you might not like the angle of approach.
The place where I'm going to enter the angle. Here you can see I'm anterior to the trabecular meshwork.
So here I'm anterior to the trabecular meshwork,
so
and
you
want to
correctly.
have the ideal position of having the Zen 1 millimeter in the anterior chamber, 2 millimeters within the wall of the eye, and 3 millimeters in the subconjunctival space. The other way to be successful with the Zen is to make certain that your supratenons and subconj. And so what you have to do is really almost point to the sky with your bevel, almost to the point where you think you're going to come through, but you're not. And you really want to make sure that it's a very superficial implantation.
Gently push the
so here you see me slowly sliding the blue lever forward to inject the Zen.
Into the
and then the first half of pushing it forward implants the Zen. The second half withdraws the bevel of the needle. You have to be very careful here. This is a critical step because while you're keeping your hand steady and the tip of the bevel in the eye, you see right there how slow you have to go for that second push. Otherwise, you'll have a flick and you could actually dislodge the Zen or break the Zen. So here you can see a little bit of bleeding that is not a big deal right around the area where the Zen is released. And you want to check where you are in your placement, make sure that you are indeed about 1 millimeter into the anterior chamber, and also that you're anterior to the trabecular meshwork.
And I will allow for greater magnification.
These disposable gonio prisms tend to serve this purpose very well. There you can see the Zen is placed.
Straw-colored Zen implant, approximately 1 millimeter into the anterior chamber. Now the important thing is to remove the viscoelastic from the anterior chamber, and it's not necessary to use a phaco handpiece.
Then you really want to make sure that the Zen is very mobile. And here you could see, I used to use the BSS cannula, and I tease the Zen and make sure that it's adequate. Here I'm verifying that it's 3 millimeters in the subconjunctival space.
Which should be approximately 3 millimeters. 3 millimeters in the subconjunctival space, 2 millimeters in the intrascleral space.
And a very low bleb is forming at this point, and here I'm flushing the viscoelastic from the anterior chamber, and you can see a nice bleb is forming. The blood that was there is being displaced now, and the Zen is nice and freely mobile.
But the implant here is going in a nice straight direction, and you can see a nice bleb. Thank you.
Hi. This is a video of the ab externo Zen implantation, which is my typical method of implanting the Zen. I start with a 6-0 vicryl traction suture through the superior cornea, and then I do these under topical anesthesia. So this is lidocaine on a WEC cell that is just allowed to sit for 30 seconds or so. I put lidocaine in the anterior chamber as well for paracentesis. Here I've marked at 12 o'clock at 3 millimeters posterior to the limbus. Now it's important with the Zen to dissect, I believe, to get in the subconjunctival supratenon space. So with this, I'm going approximately 10 millimeters posterior to the limbus, and I'm dissecting anteriorly. Here you see I'm caught in tenons. I pull back, and then I slowly dissect forward, injecting as I go on a 30-gauge needle with lidocaine to separate the layer between conjunctiva and tenons, so that when I go back in through the same wound with my Zen, I can
but
be
it
in the
doesn't impede
same
your view,
layer, and it's already
and
been
it helps to
dissected
make
for
sure
me.
that when you go back in with the
Now at this point,
Zen
what I
inserter, which I'm
do
doing
is
right
I
now, that it helps
hold the traction
ensure
suture with my
that,
left hand, and then
that you're in that space.
I
Now,
go
to get to
forward,
that
and here you see I'm
3
in the
millimeter
anterior
mark,
chamber
and
now.
just in front of it, you enter
To
into
stabilize the
sclera,
eye, I go forward with the Zen
forward
through
into the
that
anterior
same
chamber. Here you can see the
site
bevel
that
of
I
the
use the
Zen
lidocaine. Here I'm in the anterior chamber now.
in the anterior chamber.
And
there is a
you want
slider
to
to
go
push
approximately
the Zen
2.5 or 3 millimeters
the
posterior
anterior
to the limbus
chamber.
before you
The
make
first
this
half of the push
tunnel,
is,
and then you slowly
getting the Zen
advance the
chamber. The second
Zen.
half, you can
And
see
then
here,
as the Zen is starting to withdraw from the
retracted
eye, you have to
back
slowly
into the
pull
device.
backwards. And here you can see a bleb immediately comes up.
orchestrated move where you're injecting.
I err on the side of
slowly
leaving the
pulling
Zen
out,
long in the anterior
as
chamber
you're implanting the
when
Zen.
I initially implant it,
if you
because it's a
pull
lot
back too
easier to
quickly,
pull the
you
Zen
will
into the subconjunctival
underimplant
space
the
than it is to
and you don't really
underimplant
want
the
to
Zen.
over or
And
underimplant. Here
if
see
you
that,
underimplant the Zen too much, where it's not in the anterior chamber, you are
have,
forced to open the
slightly,
conjunctiva to
underimplanted the Zen,
retrieve the Zen,
and pulled back
particularly
to make
if it's
certain that, there was approximately 1
poorly
millimeter of
implanted
the Zen in the
or
anterior chamber.
underimplanted,
Here I'm checking,
because you can't retrieve it from the anterior chamber at that point. I don't put viscoelastic in the anterior chamber in order to do this technique. I simply use the lidocaine. There you can see it's perfectly placed a millimeter in the eye and anterior to the trabecular meshwork. And then through that same wound, I inject 60 micrograms of mitomycin C away from where my Zen is.
and I inject
The wound here,
60
though, I do believe is big
micrograms,
enough that it can leak, and so I do
using
close
a
it with a
0.2
suture at the end.
milligram per
Here's my
cc,
60 micrograms of mitomycin C
mixture, then that's
that I'm injecting
0.3 cc's of injection.
10 to 12 millimeters posterior to limbus, again away from the site where the Zen is.
You can use less mitomycin if you
Obviously,
want.
the lower concentration of the mitomycin C you start with, the more volume you have to use
However,
to
you
reach
will
60
have a higher healing
micrograms.
rate and failure rate. However, theoretically, with too much mitomycin, you can
And there
have a
doesn't seem to be any
exposure
trouble
rate
with
Zen.
having
In my experience,
mitomycin
exposure
C
rate is
simply
about
absorbed
1%.
over time. Here,
Now,
I'm closing
many
the
people
wound
the average
with a
scar technique,
ninovicral
many
suture.
surgeons just simply leave that hole there, but I actually make the hole a little bit bigger so that the
It's
entire
important with the
device can
ninovicral
slide
on
up there,
a BV
so that
needle
I'm being
that when
certain to
you
be
trim the knot, that you're very you cut the suture just on the knot. You really don't want to leave any tail, because then the patient can feel that.
The ninovicral and a BV needle. This way, the needle itself doesn't create any leaks. I also, you see, inject mitomycin through the same wound, so that I don't create an extra hole, even though it's a 30-gauge needle. It also can.
And then at the end of every
create a
surgery,
hole,
I
and
inject
don't even want to have
a
any
mixture of
aqueous coming through,
dexamethasone and moxifloxacin
fluorescein
from a
test,
compounded
and
pharmacy
that's the
into the anterior chamber.
Thank you very much for your time.
Here you can see I'm doing a fluorescein, a side-out test, the fluorescein strip, and there's no leak. So if you look at the data from the U.S. pivotal trial for the Zen, uh, the the purpose was to evaluate the Zen in refractory glaucoma. It was a small number of patients, 65 patients, and here you can see an ultrasound image of the Zen where if it's implanted correctly, where you have the 1 millimeter in the AC, 2 millimeters in this intrascleral space, and 3 millimeters in the subconjunctival space. And there's a low diffuse bleb rather than a large cystic avascular bleb. You can see the fine lacunae of within the bleb wall, and you almost have to rethink what a bleb looks like with these Zen blebs, because it can look like there's no bleb because it seemed fairly flat. And you can even see the Zen seem pretty thin wall. The conjunctival of the Zen seem pretty thin walled. Yet you'll find that the pressure is significantly below baseline, and there definitely is a low diffuse bleb. So in the study, there was no washout performed because obviously it was a refractory glaucoma study, and all medications, all IOP lowering medications, were stopped after the day of surgery, and the mean pressure was reduced at each visit. And you can see here, this slide is important, and I'll give you a little insight as to what I do with these Zens. It's very typical within the first week to have a pressure in the high single digits, and certainly below 14. But then often by week 2 to month 1, the pressure starts to become elevated. This is simply fibrosis forming around the Zen. You cannot titrate the Zen like you can a trabeculectomy. There's no sutures to cut. So at this critical phase, when the pressure starts to go up, one of the things that I do is I'll start an aqueous suppressant, usually a topical carbonic anhydrase inhibitor first, and that's all I'll start them on. If their pressure is over 15, I'll typically restart some type of aqueous suppressant, and it prevents a bit of a hypertensive phase that can happen, and really helps prevent early failure, and minimizes the amount of bleb enhancements. I prefer the term enhancement over needling, because it's a much friendlier term. And the number of medications that were reduced at 12 months was 1.7. So what about the left eye? Well, this patient's left eye had a cataract, and the patient is a busy dentist with high visual demands, was happy with glasses and needed to have an improved pressure, but tolerated meds okay, and needed to get back to work right away. Here you see progression of his field. Left eye is the good eye, must be topical anesthesia. So what I did in the left eye was perform cataract surgery with the iStent inject, and the vision was 20/20, and the IOP went down to 14 on 2 medications. You can see a picture of the iStent inject. This is the new inject, just the iStent inject W. Here's a video of the iStent inject, the second generation iStent inject, not the W, but indeed the inject. And really, the key and the advantage here is to target the outflow system by targeting collector channels. And I do believe that this is perhaps an advantage of the inject over the Hydrus, although the Hydrus is an excellent implant, which I don't necessarily cover in this talk, but um, uh, if you look at the data, the outcomes are likely similar, but it's difficult because there's never been a head-to-head study comparing the second generation iStent and the Hydrus. But here you can see, I definitely, you see some bleeding coming through the canal there, and you know you're in the right place. So in the future, we'll have other stenting options, the iStent Supra, which is a suprachoroidal stent, the iStent Infinite, and the which is really just 3 iStent Ws, which you can see here, and the iStar device, which is another supraciliary or suprachoroidal implant. MIGS has indeed disrupted the glaucoma surgery algorithm, and it's only just begun. Steve Jobs is known to have said that I think Henry Ford said if I'd asked customers what they wanted, they would have told me a faster horse. People don't know what they want until you show it to them. That's why I never rely on market research. Our task is to read things that are not yet on the page. And we do need to definitely be thinking differently about how we take care of patients with glaucoma. The future is going to afford combining stents with different mechanisms of action, and we'll also be able to implant sustained release implants such as the iDose at the same time. This is what's going to expand our ability to not do trabeculectomy. So you can see a picture of 2 iStent injects and an iStent Supra in the same eye. The MIG study group in Armenia has studied this paradigm of adding MIGs together, and here you can see 2 iStent, first generation iStents with an iStent Supra and 1 medication, and these patients ended up with pressures of 13.4 at 1 year. 13.4 is trabeculectomy range, and that's with combining 2 MIGs procedures with 2 different mechanisms of action and 1 medication. If you replace that medication with an iDose or some other sustained release implant, you're going to have definitely low pressures that are these types of combinations are indeed the trabeculectomy killers. So why don't do Trabs anymore? The multiple angle surgery options are adequate first-line therapy for most patients with glaucoma. Combining ECP can increase the efficacy of angle surgery and get you closer to low teens in more severe cases. There are less invasive subconjunctival options that are a solid alternative to a trabeculectomy, and the future holds ever-expanding options for the canal, the suprachoroidal space, the subconjunctival space, and sustained release medications. Thank you again for allowing me the opportunity to talk to you about why I don't do trabeculectomy. Obviously, it's tongue-in-cheek, but I think I've been able to demonstrate that if you think about it, you really can personalize the treatment of glaucoma and not do trabeculectomy and take care of your patients with the best tools possible for today. Thank you.